This conference will now be recorded.
Hi, everyone, and welcome to the AnCan High Risk, Recurrent, and Advanced Prostate Cancer video chat for Monday, August 17, 2026. I'm Len Sierra. I'll be moderating tonight with a little help from my fellow moderators, Rick and Dr. John, and all of you, our well-informed, well-educated attendees. As a reminder, this video chat is for informational purposes only. Nothing contained in this discussion should be construed as medical advice. We want to acknowledge and thank our sponsors, and they are Foundation Medicine, Novartis, Telix, and Blue Earth Diagnostics. Bayer is still a holdout, Rick?
Bayer's still a holdout, but closer.
Okay.
Thanks to, and part of that is thanks to Len. Just very briefly, the reason they've been holding out Bayer is because we have refused to report adverse events related to their drugs. We've told them that our participants can report it, but we will not report it on behalf of our participants. We don't think it's right. And they have gotten upset with us about that. And so when they do come back, they won't be, if they come back, they won't officially sponsor this group. They'll sponsor all our other groups, notwithstanding, this is the only group that uses anything they make. This is how silly it is. And in the meantime, Len has been good enough to report his interstitial lung disease, which is an issue. And they should know about. And Len brilliantly even found a citation from this past May 26, reporting darolutamide as being a cause of interstitial lung disease. So with that, I hand it back to Len.
Thank you, Rick. And we will start with Dave Begley. Dave, I'm going to ask you a few questions and try not to get ahead of me chronologically so we keep it all straight. How did you hear about AnCan?
I don't remember. I'm sorry.
That's okay.
First heard of you a couple of years ago.
Okay, and how old are you, Dave?
67 and 8 months.
Okay. And where do you live?
Gaylord, Michigan.
Michigan.
Where in Michigan, Dave?
It's Gaylord, about
Gaylord.
an hour south of the Mackinac Bridge.
Gotcha. Thank you.
When were you first diagnosed, Dave?
July of 2024.
Okay. And were you diagnosed by a GP, a urologist?
The high PSA, the urologist, my doctor referred me to a urologist. He's the one that had the MRI done and the biopsy. So.
MRI and biopsy. And what was your Gleason score?
At that time, mostly 3+3, but there was some 3+4.
Okay, and has there been an update to that?
Yeah, I tried to do the active surveillance, but after talking to the group before, they said you should get a second opinion on certain things, which I did. I talked to another urologist. He sent my samples out to get that what's that test? Decipher.
Yep.
Came back like 0.81, which is high.
Right. Okay, but there was no second opinion on the biopsy or second. Yeah.
Well, I kind of messed that up. I sent it out somewhere, but I didn't get it back. I don't know what I did wrong. But I had the next year, I had another MRI and another biopsy, and this time it came back at 4+4. And they found more lesions on the prostate. They found one the first time.
Okay.
So with the 4+4 and the higher score, that I should get treatment, or to encourage me to get treatment.
So Gleason 4+4, but more lesions in the prostate, but anything outside the gland?
No, they did a PMSA, and they didn't show anything outside.
Okay.
PSMA, sorry.
PSMA, that's all right. And you also had an MRI, and that didn't show anything outside the prostate, right?
Right.
So what treatment have you had so far? Oh, first let me ask you, was there any unusual pathology from the biopsy specimen, any cribriform or intraductal carcinoma?
I didn't get any, I don't know if they checked for that or not, but I didn't see anything on the report, and they didn't mention it.
Okay. I think they routinely check for it, I
Okay.
hope. Let's see. So what, if any, treatment have you had so far, Dave?
I had IMRT radiation, like 28 doses,
Okay.
and then they,
Just to the prostate gland?
I think she tried to do a lighter amount spread, outside. I
But
forgot
not the whole pelvic region?
I don't think it was the whole pelvic region. No, I'm not.
Okay. Okay, so when was that?
That was last September through October, middle of September to October.
Okay.
And they started me on, well, it was Eligard the first shot, and the second shot was Lupron, because I moved to a different city. I used to be in West Virginia, and now I'm in Michigan.
Okay, so I think I forgot to ask you, what was your PSA before the radiation and after?
Well, before, it was never that high. 6 was the highest I ever was.
Okay.
After, now it's, it doesn't register. It's
okay. You're undetectable PSA right now.
Yeah.
Okay, so you haven't had any additional treatment besides, well, you're on the hormonal therapy.
Yeah.
Is it just Eligard, or is there a second agent?
No, just that.
Okay. How about genetic testing of any kind for germline, which would be inherited genes, or somatic mutations, which would come from the tumor cells themselves from the prostate biopsy?
No, I haven't done anything.
Okay. I think we recommend you talk to your doctor about getting tested for genetic mutations because you're high risk.
Okay.
All right.
My follow-up with the urologist is in a few weeks, so I'll just make notes of what to ask him about.
Okay. We suggest that unless you have urinary issues, we suggest you get a medical oncologist to be your quarterback, and he should be someone who specializes in prostate cancer. So we call that a GU, medical oncologist, genitourinary medical oncologist. Okay.
I had one in West Virginia when I had the treatment, but now we've moved, and I've kind of dropped the ball on things, so I can get. I haven't got an oncologist up here yet, but I'll find one.
Okay.
It's not just an oncologist you need. We recommend a genitourinary medical oncologist. They're hard to come by.
Okay.
There may be somebody in your area. We have a gent called Steve Rue, and I think he's found somebody up towards where you are. I don't exactly know where Gaylord is, but I will reach out to Steve Rue and connect him with you, because a common or garden oncologist is not really going to be the right type of doctor for you.
Okay. All right. So how did you tolerate the radiation treatments and the hormonal treatment so far?
So far, it's been okay. I mean, I don't really like all the hot flashes, and I get tired easy sometimes, but it's
Okay.
it's
Par
too
for the
bad.
course. If you need
Apparently.
help dealing with hot flashes, we've got plenty of guys here who would offer solutions for that if you're interested.
Okay.
Anyone want to talk about the ember wave or acupuncture or anything else that you may have experienced?
Well, I have a feeling we may be coming back to this with Mr. Blomquist from my earlier conversations with him today.
Okay.
So,
I don't want to barge in and take up all the time, so it's
okay. Well, we do have Neil Sundstrom. Go ahead, Neil.
Yes, good evening. The Ember Wave, I have used it. Dave, I don't know if you're familiar with it, but you can get it at Costco, and it's worked very well for me, and I know it's worked well for my brother as well. You just put it on and set the dials and set them once, and then it really works for the flashes.
okay. Appreciate that. Never heard of it.
You wear that like a watch around your wrist.
Okay.
And I've never used it, but what I understand is when you feel a hot flash coming on, there's a button you press. I don't know, Jeff Markey, there he goes. Go ahead, Jeff.
Okay. There's two buttons. One you can set for daytime, one you can set for night. Because are you getting the hot sweats at night that get your sheet wet?
Yeah.
I've got to actually have instructions for how to configure it for use for both buttons, the ideal configuration. I've given to a lot of people and they love it. Like if you post your email in the chat, I can send you a copy of those instructions.
So the other thing that may be helpful is that we just made a blog post on cooling wearables, and right above where you've put your email in, if you click on that, you'll find a nice pink pelican with some great suggestions, including the Ember, on ways to stay cool from hot flashes. And there's all kinds of stuff in there, from Bob Alvord's personal evaporative cooler, which I like very much. It's very ingenious, to the Ember Wave, to a new piece of equipment that maybe Barry will mention when we come to him shortly. But there are a lot of solutions. We try not to have you suffer.
Cameras or everyone. Sorry, folks.
Okay.
Okay, sorry, guys. Dave, do you have any questions for us?
No, I just wanted to rejoin and get caught up on things, which you can see that I have.
Yeah.
Need to do that. So I haven't really gone to the right doctors or tried to handle my hot flashes or anything. I just been winging it on my own. So
I have a couple of questions, Dave. How long have they placed you on hormone therapy for?
18 months.
Okay. And you've done what, about 6 or 8 months to now? 9 months to now? No, more.
Yeah, I've actually
Almost
done.
a year.
I got my first one in the middle of September, so I'm almost a year.
Yeah, you're going on a year. Excellent. That was one thing. What was the other thing I wanted to ask you? It went out my mind.
Probably maybe the vet question.
Oh no, I don't. Do we?
Well, we have
do we
Dr.
ask?
John. While you're thinking, Rick, we'll go to Dr. John. and then Dr. Pierre. Go ahead, guys.
I was wondering if anybody in your family had any type of cancer, Dave.
I had just any kind.
Any kind.
Yeah, I had a younger brother that died of testicular cancer.
Oh, okay.
Mother had some kind of stomach cancer, and my father had some sort of. He said it was, and I can't remember. He didn't really specify the name, and it's been years ago now, and I got it written down somewhere. But yeah, all different kinds.
Okay, well, another good reason to get your genetic testing done, just to make sure. Dr. Pierre, go ahead.
Go ahead, Dr. Pierre.
We can't hear you.
We-
Your mic seems to be on, but we can't hear you.
Yeah, we could hear you before, so maybe check your mic, see if it's switched you. Go-to does that, and if it's not the mic, come out and back in again. We'll get back to you with your comment. My comment to you, Dave, is what are you doing for exercise right now?
Lots of stuff. Joined the gym to start lifting some weights, work on the elliptical, and I like to run, although I kind of hurt my MCL, which has sidelined me for a while. But
Yep.
Okay, and I talked to you about diet.
yeah, I don't. I get plenty of cookies and
Avoiding red meat.
Really?
That's what they say.
Oh, okay. No, I don't eat a ton of red meat, but I don't avoid it either. So
I mean, occasional steak is not going to hurt you, but I think the general consensus is Mediterranean diet, really, you know, lots of fruits, lots of vegetables, chicken, fish, that sort of thing.
Okay.
Oh, let's see. We've got another question. Neil, go ahead.
So Dr. Pierre held up a sign. I don't know if you saw it, said, ask about a DEXA scan.
Oh, I didn't see it. Thank you. Did you have a DEXA scan, which is a bone mineral density scan?
No, I haven't.
Probably a good idea since you're on hormonal therapy.
Okay.
Just get a baseline, although you're already on hormonal therapy for 9 months, because hormonal therapy and sometimes the radiation too can leave you with osteopenia or osteoporosis. In which case, they can give you a medication to supplement your bone strength. So ask about that DEXA, DEXA.
Yeah, somebody put it in the chat because I'm glad for that.
Good, good. All right. We can now catch up with Richard Craymond, who we had to skip last week. So go ahead, Richard.
Thing is easy, I hope. I finished Pluvicto back around the 1st of June. Did the PSMA PET scan, and it came out totally negative. Where prior to Pluvicto, I had the lymph nodes on the left side, basically up the abdomen, light up. So that was good news.
Yeah.
And I got the CAT scan and bone scan. The bone scan still shows the same as it always has. No signs of cancer into the skeleton. Only thing it showed is I broke my little toe at a wedding, at my son's wedding in June. But the CT scan is basically still shows all the nodes in the lungs, too numerous to count, as I keep saying, that haven't changed. They're still there. The lymph nodes, I said, a mixed bag. They are reducing in size on the left side, iliac reducing, and there's a slight increase in size on the right side. So it's kind of a mixed mode, but no real growth. Those were like millimeter deltas, so in size. So that is good. I go see Dr. Allen about the results on the 25th. I saw Mark Makowski earlier in July, and he's actually recommending I go on so
You go on a what? We missed that, Richard.
On a drug holiday. Basically, the only thing I'm on is the Eligard Lupron, and 3 months will be coming up at the end of this month. But he's recommending that I go off of it. And I know he and Dr. Allen, Josh Allen, have talked now before the meeting with Allen, so we'll see what happens there. Otherwise, I'm feeling great. So so far.
So with all those lung lesions, you have no issues with breathing?
No.
Did they recommend you see a pulmonologist?
No, I haven't.
All right, Dr. John, go ahead. You have your hand raised.
Thanks. Richard, I need a little education about this. I think I understand that the PSA is pretty much useless when you have foamy gland cancer.
It's just shown up as undetectable.
Yeah,
now,
but what I don't understand is how do we interpret PSMA PET scans or CAT scans in a person with foamy gland carcinoma?
So far, the PET scan has been interpreted based on the PSMA attachment to the glands themselves. They
but
lit
if
up.
your PSMA
No,
PET
that
scan
is gone.
Yeah, so if your PSMA PET scan is positive, we know that means you've got some prostate cancer.
Right.
And if it goes negative, we think that means you responded to treatment. But a negative PSMA PET scan, for instance, all these things in your lungs don't show up on a PSMA PET scan.
They do show up.
Oh.
On the PET scan itself, they could see the nodes.
Oh, I thought it was negative now. Okay, I understand.
No,
Thank you very much. That clears it up for me.
They don't grow.
Because you said the CAT scan was positive, but
no, the CAT scan. I probably misspoke, but the CAT scan clearly shows, and I've got the, I had that every 3 months before we got to Pluvicto. So I had a good tracking of some of the, what do you call them, baseline or you had a name for them. But anyway, they can go find specific nodes and measure them and use that as a measure, some kind of measure. But they don't go away. At one time.
So let me clarify, Richard. Let me clarify. So on the PSMA scan, we see a certain number of lesions, and we also see all of the foamy gland lesions. Is that correct on the PSMA scan?
That's true.
Right. And the result of the Pluvicto is that all those lesions that were not foamy gland have disappeared, but we're still seeing the foamy gland lesions.
No, the foamy gland lesions have disappeared. In other words, they lit up, and now after Pluvicto, they did not light up. So the PSMA that would be attaching to any of the lymph nodes.
Okay, so let me try again. So the Pluvicto has cleaned up everything, including the foamy gland lesions on the PSMA. However, those foamy gland lesions are still visible on the CT scan.
Yes.
Okay, Dr. John, are you receiving?
What I want to make sure of is that we have a reliable biomarker that does indicate the presence or absence of his cancer. And it sounds like the answer is yes. Do we agree that between the CT scan and the PET scan, that we are able to follow his waxing and waning of the cancer? I just wanted to make sure that with these foamy gland lesions, that all of our biomarkers are not useless.
Yeah.
Well,
the bigger question is, and Josh Allen is actually wanted to do get a biopsy of those lesions in the lungs. And the interventional radiologist said he doubted that he could actually get them reliably with a needle. They're small. They're less. The biggest one is, I believe, 8 millimeters major axis. So it's not like they're, doing much else.
Right. So, I think the problem is, maybe Dr. Poole knows more about this, but I think the problem is that we did not think foamy gland produced PSMA, and we know that Richard has a mixture of 2 types of cancer, including the foamy gland.
Yes.
However, they may have shown a little bit, because at one point the foamy gland did show up on the PSA, did show up, and now they don't show up. Not sure what the reason for that is, but they do show up on the CT scan. I mean, the question that goes through, say, Dr. John's mind is, are we sure that those are foamy gland, or is it something else?
No.
Is it fine, or is it...
Markowski and Alan both agree they're not sure what it is. All when I had a TERP, it was consistent. It was the foamy gland, and it matched the first biopsy that I had. No other carcinoma has shown up.
Okay.
That any evidence of it. That biomarker, I think they're going to try doing something there, but right now.
So, Dr. John, I think that we just have to trust Dr. Allen and Dr. Markowski, that they understand how to manage. Dr. Paul, do you have anything you want to say about this foamy gland prostate cancer?
No, but in the presence of a negative PSMA PET with visible imaging lesions, foamy gland aside, the typical next step is to get a FDG PET scan, because maybe it's another cancer, or maybe it's a cancer that doesn't light up PSMA PET as typical prostate does. So, but the foamy gland is beyond my knowledge base. But what is causing these persistent enlarged lymph nodes and lung masses, I guess, is a question that you guys know more about, but I would say I'd be worried about another cancer, as you've mentioned.
Yes.
So Richard, Dr. Paul's got a good suggestion there. When you talk to your doctor, ask him about what he thinks about the utility of doing an FDG scan to...
FTG?
Yeah, FDG, Frank David George.
Okay, that may be, Len, what the other CT scan is that we're talking about, because he's getting another CT scan, and my suspicion is that's what that is.
Well, the FDG is a PET scan, though. It's not a...
Yeah.
It's not a CT scan.
Okay.
No, it is, the CT is, technique is DMP intravesic. Oh, okay, injected with 26.5 millicuries of PC-99M MDP intravenously.
What is that, Len?
I have no idea.
Okay, I'm just reading off of the
tests.
Oh, pardon me.
Anybody know what that is?
Okay, that was the bone scan. I'm sorry.
That was the bone scan. That's what I thought.
Okay.
Was that technetium?
Yes.
Yes.
Okay.
So you had a PSMA scan and you had a technetium bone scan. Did you have any other types of scans, Richard?
No.
No.
So the PSMA.
Okay. And so the PSMA that was, those foamy glands that were showing and no longer showing. So I absolutely agree. But wait a minute. Did you say that they showed up on the bone scan, the foamy gland?
No. Nothing showed up on the bone scan.
Okay, so how do you know? And those PSMA, they didn't show up on the PSMA scan either now, correct? Or they did?
They did not.
They did
No
not. So how do you know?
PSMA.
How do we know they're still there?
They're very clear on the CT scan.
Okay,
And
wait a
those-
minute. I thought you said we had a bone scan and we had a PSMA scan, but no other scans. But now you're saying there is a CT scan.
Yeah, yes, that's what I just got done telling you. I just had
Okay,
the
so
CT
they show up on
and
the bone scan. So they do show up on the bone scan.
No, they do not show up on the bone scan.
Only on the CT scan.
Only on the CT.
Okay, but what is?
I have always had negative on the bone scan. The only thing it's the bone scan has shown up for the last 5 years when I was having it every 3 months.
What is
broken?
What is the CT scan? Is that the CT scan that they're doing to position you for the PSMA, or is that something else? What is that CT scan?
I don't understand what you're saying about positioning.
I think it's probably a separate, separate CT scan.
Yeah,
I don't think it's a PET CT scan.
It is not.
Yeah. Okay. Okay. Yeah, I think we're going in circles here. We better move on.
But
let's wait till
what you're
Richard.
saying is there's an FDG.
Yeah. FDG is fluorodeoxyglucose. It's not important to know that. He'll know what FDG is.
Yeah.
It's basically a radioactive glucose, which, if your cells are not PSMA positive and there's still cancer cells that are growing, they'll pick up glucose, radioactive glucose, and they'll be able to see that.
Okay.
All right. Yeah. So you talk to him about that. Let us know what he says next week or whenever you see him.
It'll be after the 25th.
Okay.
Because
all right, thanks, Richard.
I'll see both of them again.
All right, very good. Let's go to Barry.
You said Gary?
Gory? Oh, yeah, this is me, Gory, right?
Oh, Gory.
Okay.
No, Barry Blomquist.
Oh, sorry.
That's all right.
Okay.
Go ahead, Barry.
So the only thing I had to kind of update right now was particularly with regard to the cooling mechanism.
Barry, could you
device.
get closer to your microphone or something? You're very soft.
Is this better?
Much better, yeah.
Okay. I just mentioned to Rick that I've been doing some testing lately on cooling devices, and I got my hands on this one from Sony right now, which is kind of a strange looking device. And we've had the links in the group chat earlier, and I'm going to be working on a little report for Hana, I think it was, that Rick had told me I should send it to, as well as himself. And and then we've talked before with regard to the cooling devices on the fan and the vest. So there's some hope on the horizon, because in testing these different devices, they work in much different ways, but they seem to be performing pretty satisfactorily, depending on the kind of conditions you're in, to reduce hot flashes and provide more comfort. And the last one, well, there's a couple other ones out there that I'm pursuing as well, particularly for night sweats, which are cooling sheets. And there's some cooling bedding technology. But anyway, making some progress on that. I think there's some significant hope with regard to these new technologies, and I just wanted to share that a little bit now and provide more information in the next couple weeks or so.
How does that Sony device work?
It's a really strange device. It has no moving parts. I'll back it off a little bit here. It has no moving parts. It has a little metal shield, and it goes on your back. So it slides down behind your shirt collar and lays on the upper portion of your back. And when I initially got it and tried it,
I thought, somebody's been, chasing engineering concepts that have no real hope. But believe it or not, it has a real subtle impact on how you feel, how cold you feel. And I don't know if it's working on some of the nerves that run up the back, but I've been wearing it for a few minutes now, and even my upper back and lower neck are still cold from putting it on. It is battery powered, it's rechargeable, and the plate develops it actually gets quite cold. And then it has a little teeny vent on the top that also pushes a little cold air up onto the back of your head. And the longer I use it, the more I like it. And it's fairly innocuous. The problem with the neck fans is they make a lot of noise. And of course, you look like a plow horse and with the thing around your neck, which also works good even with a towel around it.
So one other question, Barry. Dr. John is concerned about how you're doing with your urinary blockage. Do you want to fill him in on that?
Oh, well, for those in the group that aren't familiar, I went through a debulking procedure and had 4.5 weeks of radiation treatment to my prostate. It is a very unhappy camper right now. So I'm self-cathetering 4 to 5 times a day. And I've been doing that now for almost 3 weeks. I got a message from Dr. Yang at Mayo today. And, he said that this could go on for 4, 5, 6 weeks, potentially longer, depending on my condition. And so I don't mind the self-cathetering part. It takes me 15 minutes to convince myself to do it each time, but eventually, it gets done. And you get a little bit of minor pain because sometimes your bladder and your current situation don't sync for having to go through it. So you do have some pain with it, but purportedly the urethra will eventually open up and I'll be able to urinate again. So all you guys who are urinating fine right now, trust me, it is a blessing.
So is your treatment on hold?
No, I completed my treatment.
Oh, you did all the radiation therapy?
Yes, I'm all done.
Okay.
Yeah, I'm all done. About 5 days in, I was starting to have trouble, but Dr. Heath intervened and said, I suggested I should take a break, and she intervened and said, stay the course. Let's get this over with. It's a good process, but you kind of got to get where you got to get to, and eventually the urinary issue will resolve itself.
You got 20 treatments in of radiation therapy? Wow, okay.
Yes. Low dose.
So is there anybody in the group who has had a urinary blockage as a result of doing radiation therapy? And if so, and they've had to self-catheterize or they've had to get a Foley catheter, and if so, how long has it taken for the inflammation to subside? Yes, not tonight, but we've definitely seen it, right?
Red?
Yes.
I have a urinary blockage. I'm 5 months out from my 28 doses of radiation. I'm still self-cathetering probably 80-90% of my urine.
Okay.
So there is some improvement, but not back to normal.
So you're 5 months out, you've been self-catheterizing for 5 months and you see improvement. Are you able to urinate yourself at all?
Yes. Maybe 10 to 20% of my urine volume I can do on my own. I think it's in response to the medication. I forget the name of it. Seems to work in the afternoon after I take it, and then kind of dissipates. But self-catheter 6 to 8 times a day.
You have my empathy, Gary.
And Lee Balin.
Yeah, Rick, my blockage was not radiation induced, but I self-cath for nearly 5 years, and I've now had an indwelling suprapubic Foley for the last 6 years. So if anybody here wants information on catheters, shoot me an email, and I'll be very happy to fill you in on the tricks of the trade and living with those things.
Okay. No, thank you. I was really just trying to get a handle for Barry on how long he may have to be doing this. And when we spoke earlier, I told him it could be a while, but.
Rick, yeah, so much depends upon the symptoms the patient is having before the radiation. And that's something that needs to be clarified. And if there are issues, a cystoscopy done, because if you have a prostate is large, both from a CT scan measurement and also how much intrusion on the urethra is present. And the two do not always compute as being the same. And the radiation obviously does cause some inflammatory reaction, but if you have significant intrusion pre-treatment, it's going to be tough to expect it to resolve even with radiation, as I will say, atrophy as time goes on. So something more sometimes needs to be done.
Barry, did you have any urinary issues before treatment?
No.
Okay.
No.
Thanks, Dr. Paul.
Okay.
We hope we'll get you back to peeing normally very soon, Mr. B.
Thank you, guys. Appreciate it.
Okay, thanks, Barry. Gary, it's your turn.
Thank you. My husband, Mark Richards, is diagnosed with the localized Gleason 9, and so he's on ADT since April 17th this year on Orgovix, and his Dr. Roach has planned his radiation is done, 2 SPRT and 25 IMRT. In the month of July until August 10th. So that's the status. Now his GU medical oncologist is Dr. Friedlander from UCSF. I asked him if, because I have a friend here in this group, Jeff Marche, who has been tremendously helpful. He has been my mentor in some ways, helping me. So he said that ARPI and the ADT together helps in not being castrate resistant, etc. So I had some information. Well, I asked him, ARPI for Gleason 9 will be good or not. He said he discussed his case at the tumor board, and the answer of the board was that because there are 3 criteria, he meets only one, which is grade group 4 to 5. But he doesn't have his CT1 not palpable, and PSA was under 40. So he said the board thinks it's not necessary, but if it gives you peace of mind, you can go ahead and I can prescribe abiraterone. So we said yes, just to be on the safe side. But he also Mark had full knee replacement surgery on January 27th. And in January 26, he was also diagnosed. The biopsy was done, and the PSMA was done on February 27th. So what was my point? I'm forgetting now.
What is
So,
your question?
the question
How can
is,
we help you, Gary?
the question is, will ARPI be important for his treatment or not? As Friedlander said, Dr. Friedlander said, no, it's not necessary because he meets only one criteria. That's my first question. The second question is, he had DVT was found during his knee replacement surgery. He was put on Eliquis for 5 months. He just discontinued that. And now if he gets abiraterone, there's a steroid, and blood thinner will be necessary. Can you please give some feedback? How will that work if we use abiraterone with a blood thinner?
So Len, let me. I have some thoughts on this, but let me defer to you first as the moderator.
Right. Well, the three of us, you and Dr. John and I, exchanged emails about this. We didn't see any concern about using abiraterone with because your husband had Eliquis, because
Yes.
the Eliquis was due to there was a specific cause for his blood clot. It was a surgery. So as far as our consensus was concerned, there's no reason why he couldn't have abiraterone. There's also no reason, I'll speak for myself, no reason why he couldn't have darolutamide instead of abiraterone, unless your doctor just can't get it approved for you.
Yeah, we appealed, and they refused. The insurance refused.
So,
yeah, go ahead.
I'd like to address that one, Len.
Yeah.
I'm not sure who's recommending the doublet. Is this something that Jeff has said he feels you should be on? He would be on it, or where does the doublet therapy come from?
I did mention to her that it reduces the incidence of castrate resistance.
Yeah.
People become castrate resistant sooner if they're not on an ARPI as well. And since he's a Gleason 9, an ARPI is frequently called for, but
no, Jeff, you got to look at the NCCN guidelines. The doublet is only called for if you are stage 3 and you have lymph node involvement. So it's not. Is it prescribed? By certain doctors, like say Dr. Schultz. Yes, they will prescribe it, but it isn't standard of care. And a lot of doctors don't feel it's necessary, and they're happy to prescribe ADT because these people are not going to be on hormone therapy for a long period of time. Hopefully, it's only going to be 18 months or so.
2 years.
Even with a Gleason 9. Now, he's a T2. And Dr. Fried, he's T1 or T2. He could be a 4+5 T1 or a 5+4 T1. So Dr. Friedlander, who I have a great deal of respect for and known him a long time, and he's, in my view, an excellent doctor.
Yes, he is.
Is saying, look, you don't need a doublet therapy right now, because your cancer, whilst aggressive, is not that advanced. If you're nervous, I would be willing to try and get you abiraterone.
Okay.
Because that's what the NCCN guidelines suggest. The NCCN guidelines for stage 3 only approve abiraterone. They don't approve all of the ARSIs.
He will give that to her if he will give that to her. He said that.
Yeah.
Well, we know that. But can you get darolutamide? Maybe a doc like Schultz might be able to get it. I don't know how. I don't even think Dr. E could get Nubeca for for the Richards. So I would say, if you really feel you want another drug, and I don't know if it's necessary. I mean, I was T3 and I only got a singlet, but that was having to do with the time. But even today, people with T3, T3A, they're only getting singlet therapy. So my feeling is, if you really wanted the doublet, you're going to have to make do with abiraterone and the prednisone.
Okay, so one more thing I want to say is he's on Orgovyx and he has a blood pressure medication, lisinopril, 10 mg. He's splitting it into 2, 5 morning, night, but somehow the Orgovyx is really dropping his blood pressure. He feels lightheaded during the day. There are moments. And so I talked about it to Dr. Friedlander too. Now, if we start abiraterone, and I don't know how all these things are going to interact. The Orgovyx is dropping his blood pressure. There are times it goes up, but he notices the drops because it's really
well, do we know it's the Orgovyx that's dropping blood pressure? Because we would expect an ADT drug to raise blood pressure and not drop blood pressure. Len, what do you know about the cross interaction? Or Dr. John? Or Dr.
Let's get the name of the blood pressure medicine and I'll look it up while we're talking.
She mentioned lisinopril. Lisinopril, Dr. John. So, you know, we make these assumptions, but we don't really know. And it's not what we would expect. In most cases with androgen deprivation therapy, blood pressure goes up and not down. It's a metabolic syndrome, and this week we'll be putting something in the reminder about metabolic syndrome, and it's a frequent observation that on starting any ADT medicine, including Orgovyx, that they have seen a rise in blood pressure. So a drop in blood pressure is a whole another ball game.
I don't know why, but it's happening. Yeah.
Well, it may not have anything to do with the Orgovyx. I mean, you're assuming the Orgovyx, but where does that come from?
Because now he was taking 10 at a time, mg, and that was really making him feel bad. And then he split it into 5 morning. It was still causing here and there lightheadedness, intolerable.
You're talking about the lisinopril, right? He split.
Yes, and now for the last.
Why is that from the Orgovyx? I mean, there could be other things. You've said, oh, well, he's on the Orgovyx. You know what? He can stop the Orgovyx and get a Lupron shot.
Oh no, that's
try getting a Lupron shot or an Eligard shot.
No, because he's not having bad hot flashes. He's on the whole, he's doing fairly good.
What would you like to suggest? What is it that you want from Dr. Friedlander? Len, I'm going to pass this over to Len because
I'm curious, Gary. How long has your husband been on lisinopril?
For a long time, even before diagnosis, he was taking 20 with his, the PCP said 20 mg. It was working well at that time, but since he's on Orgovyx, he was having problems. So it was reduced to 10. And then he started splitting it into morning and night. And for the last 2 days, he just took 5 mg because PCP had approved in case you want to try. And now with 5 also, he felt very lightheaded today. So it's not even we don't know. Even Dr. Friedlander was clueless about it.
So he's feeling lightheaded, but when he's lightheaded, are you checking his blood pressure? Is it because of his blood pressure?
Yes, we are.
How low does it go?
Right.
Well, his normal, according to him, is 125 upper one, but it goes up till like 105 or sometimes
very low.
but no, the higher one and the lower one, I have to check what it is. But that is low for him. You know.
Is he well hydrated? Because I've had this problem of lightheadedness, near fainting. My blood pressure is, without being on medication, is normally about 105/70. And they said, you need to hydrate more. I did, and that lightheadedness went away. So you might want to try that.
Yeah, he's hydrating a lot because like this bottle, he at least has 4 of them, or with electrolyte.
Okay. Yeah. All right, and that's good.
My last question is, PSMA said it's localized, but 80% is correct. 20% chance lymph nodes. I'm glad we have Dr. Macrosh. She's a great RO, but the chance is that it could be in the lymph nodes or somewhere else, you know. And so the only reason ARPI was interested in was as a safeguard that I should not repent after 2 years when I hear that there's a reoccurrence, and I repent. I wish I had added ARPI. That's my feeling.
What is your husband's PSA currently?
It was tested on July 17th. It was 0.8 PSA. Testosterone was 13.0, and he was on Orgovyx since April 17th, 2026.
So his PSA is 0.8.
He actually just finished treatment. So radiation, so we won't have it tested for what the results of all of the radiation.
That was on July 17th. He was in the middle of radiation at that time, 0.8.
And he's been on Orgovyx since when?
April 17th.
So that is something that I would definitely be discussing with Dr. Friedlander. Because if he's been on Orgovyx for 4 or 5 months, and he still hasn't dropped below 0.2, then that is a concern.
0.2, but we don't know as yet what is the current PSA, because it has not been tested.
When was the last PSA taken?
July 17th.
Okay, well, July 17th is a month and a half ago, and he was still at 0.8.
Yes.
That's kind of high after 3 months. So get another PSA. You can get a PSA easily enough, and let's look at what it is, and that might be a point of discussion.
Oh, could it be a radiation bounce, Rick?
Not right away. That he just finished radiation, Glenn.
Okay.
On August 10th, he finished it.
PSA was before he started radiation, wasn't it, Gory?
That was in the middle of radiation, because he started radiation on July 1st, and or maybe July 2nd, and this was on July 17th. Testosterone and PSA test.
Well, there's probably no rush to get a second drug, if ever. Like Rick is correct with his staging, TNM staging. The recommendation is not to be on doublet therapy. So maybe you just need to wait and, see what happens to the PSA. How often is he getting it checked?
Well, he just finished. So Dr. Friedlander has given him, he can do every month. But we just had a meeting, and he said you can do it, by the end of this month. We can keep testing every month if we want.
Yeah, okay. Keep an eye. So get it tested periodically and keep an eye on the PSA. And, don't panic, just relax. Dr. Friedlander will know when and if it's as doublet therapy is called for. But,
I just want to ask you about his PSA.
We have to move on, Gauri. I'm sorry. We've got a lot of people.
Okay. Yeah, and I got it. Thank you very much for your time. I really appreciate that.
Thank you. Okay. So we'll go next to Bill Lawler.
It's just a brief update on where I'm at.
That's why I wanted you to come to the meeting. I wanted to get
Jeff, could you mute?
Sorry.
Okay. Bill Lawler, are you with us?
I'm here. Yes, sir.
Okay, go ahead.
It's just an update on where I'm at here. I've been on ADT with Rebecca and Relagolix now for a month and a half, and a little bit of the hot flash thing going on, and a little bit of urination increase in frequency and decrease in volume, and a little bit of energy loss. But other than that, it's going pretty well so far. This week I have an appointment with a radiation oncologist to talk about the radiation treatment. And on Wednesday, they're going to install the rectal spacer and the placement.
What type of radiation are you getting, Bill?
28 treatments.
MRT, okay. And what were you, Gleason 9?
No, Len. This is a long recurrence. This is a recurrence after many years. 9 years isn't it?
9 years was the original diagnosis.
Yeah, it's not really even a recurrence. It's Bill's been on active surveillance for 9 years, and then a Met showed up in his femur, in his iliac bone. Thanks.
Okay.
So he's been seeing Dr. Chowdhury, and the idea and the thought is now to radiate, and I think they're going to radiate the prostate, right, Bill,
right,
for the first time?
Yes.
And as I recall, the spot on your iliac bone was difficult to get at, so they were deferring the spot radiation on the metastasis.
Correct.
Right.
Okay.
So, this has been going. It's an unusual case. Unfortunately, we tried to get Bill into the Andromeda trial, but because he has the metastasis, but he never had an original intervention, and so they don't consider him to have recurred, which is a requirement for the Andromeda trial.
Right. Okay, so you're just giving us an update, Bill, or do you have questions for us?
No, that's it. Pretty much just the update on where I'm at there, and any advice. And I was reading Howard's active surveiller today, and there was a new ADT kind of treatment that he was chatting about. I don't know if anybody had read that.
A new what? I'm having trouble hearing you, Bill. A new what?
In Howard's active surveiller that came out this morning, he had talked about a treatment called estradiol.
E2.
Okay. E2. So we've talked a lot about E2 here, and Dr. Paul is the absolute expert. And if you look in our reminder from this weekend, we're advertising a webinar that will take place on Thursday, the 20th, in which our very own Dr. Paul will feature as a discussant. And we strongly recommend you attend that webinar. It will be at noon Eastern time, and you'll learn a little more about E2. It is nothing new. It's been around a long time. What is new is that on its own without any other drugs. It has now been shown to be effective, but it hasn't been approved in this country yet. Am I saying anything wrong, Dr. Paul? Go ahead.
Well, yeah, not exactly, but
Okay, go ahead.
The big switch is that it's delivered transdermally, which is safe, and the prior estrogen compounds were taken orally and caused, because of the liver exposure to a high load of estrogen, causing the liver to produce thrombotic proteins, cardiovascular and DVT were high and overrode any therapeutic benefit of the estrogen. So it's still a estrogen suppressing testosterone, but now by a very safe route of administration. And with regard to Howard's letter, he was pointing out that when folks like you, Bill, on active surveillance are faced with the need for active therapy that might include androgen deprivation therapy, to be aware to discuss with your medical oncologist the various options available, one of which is transdermal estradiol.
Excellent. Thank you.
Thank you.
I'll tune in Thursday. Thank you.
All right. Thank you, Dr. Paul. Bill, we got a lot of people to get to. Is it all right if we move on?
Absolutely.
All right. Thank you. We're going to go to Danny Langford. Go ahead, Danny.
Hey guys, just a quick milestone update. You hear me okay, Lynn? Good
Yeah,
volume.
beautiful.
Yes.
I a couple of days ago finished my docetaxel chemotherapy. Thank goodness. I didn't think I was going to make it, but I got through that. I got radiation prep coming up in a few weeks. They'll give me a few weeks to recover from chemo, and then I'll begin radiation. It'll be, I think, EBRT, maybe 25, 27 rounds of that, or sessions of that. I got a ton of questions, but I want to ask about I'm on the darolutamide and the Relugolix, Nubeqa, and Orgovyx. And, I had some questions with my GU oncologist about that. Like, how long should I expect to be on it? And I hear you guys talking about 18 months or 2 years or whatever. And I'm just kind of curious, what's the norm? Is it a year and a half? Is it 2 years? Is it as long as you can tolerate it? I mean, especially for me, someone who's 50 and Gleason 10, PIRED 5, metastatic stage 4 and all that stuff. Am I going to be on these two meds forever, or is it going to stop at 2 years, the hormone and the ADT?
Let's go to Bob Schwartz, because he had a similar experience, similar staging like you, Danny. How long were you on hormonal therapy, or are you still on it, Bob?
Still on it, Len. I'll be 2 years come November.
Okay, and what are they recommending for you? Just, are you near the end at 2 years, or they want you to go longer?
I think I find out when I see the doctor again in a couple months.
Okay. So Danny, certainly one consideration is going to be, what is your PSA at the end of 18 months or 24 months? If it isn't undetectable, they'll probably want you to continue.
Yeah. So far, it's pretty hormone sensitive. I mean, I'm 0.02 on the PSA, and my testosterone is 1. It was 1 yesterday. So, I'm responding well, like I should, to all these things. I'm just I was stressing about, like, God, how long am I going to be on these medications? Because I did, Rick and team, I took the oxybutynin to try to mitigate the hot flashes, which I have nonstop, 24/7, just relentless flashing and body temperature issues. And oxybutynin didn't do anything. And, I tried the Emberwave, it didn't do anything. And so, I don't know, I think I'm just going to have to get a construction job so I can just sweat, and who cares if I sweat?
Well, what about maybe you should talk to them about estradiol. We're pretty sure that will take.
I did. You know the story there with Dr. Antonarakis. He DBT. He's like, but I hear Dr. Schellheimer talk about the route of administration through transdermal versus oral and the pros and cons of that. And so I think it may be in my future. I just got to find a way to get there. Because I don't think my current oncologist supports it.
Yeah. Well, I don't think there's no longer an issue of should you take it orally or through the patches, because they definitely won't give it to you orally. We know for sure that'll cause thrombotic events. But yeah, maybe you just have to make your case to Antonarakis. Hey, look, doc, please, I'm suffering with all these hot flashes. Can we at least try low dose estradiol? Or if you won't do it, can I go to an endocrinologist maybe? I don't know. What do you suggest, Dr. Paul? Can he go to, who should he turn to?
What you just said, Len,
yeah.
Don't change anything you're doing with regard to the ADT program. Just ask if you can use 1 or 2 patches a week, which will solve the hot flash problem, which is obviously really rough on you. And I can't imagine him not empathizing with your problem and solving it with something that's not in place of everything good that you're getting, but just an add-on. I mean, it's kind of like working with the fan and the pat or the particular other mechanisms for hot flashes. This will work. So I ask him again.
Yeah. Thank you.
And Bob Schwartz, I think you're taking estradiol now, right? And is that working for you with the hot flashes?
Yes, it is. It's helped. It doesn't make it go away. I'll be honest with you, but it helps. And I'd like to ask Dr. Schellheimer, if I could, what is the proper dosage? See, right now, I started at a low dose and I'm working my way up. But what is the proper dosage to be on it for maintaining it? What's the highest dosage you should be on?
Really, the proper dose is a bit variable and dependent upon your symptoms, but usually 80 to 100 picograms per ml, which 1 patch twice a week, maybe 2 patches twice a week will certainly deliver. But I mean, we're only treating symptoms, and for some folks, 60 picograms per ml will relieve the hot flashes. For others, it may take 80 or 90. You're not trying to do anything other than symptomatically improving your hot flash status, and that's the dose that's appropriate. So have you had your serum estradiol measured perhaps about the day after you put a patch on?
No, I haven't yet. But right
yeah,
now,
it would be worth doing it. I mean, I'm just giving you a rough 80 to 90 would be something to kind of move towards for good relief.
But I'll tell you this, Dan, if you can get the E-patch, do it. It is beneficial. You got to find the right doctor that's going to prescribe it for you. And my doctor's kept me on a real low dose to start, and then it's allowed me to work up. So I'm on the 3rd degree of the patch so far, and I got 2 more to go before I reach the 0.1. So I'm working my way there, and it is helping. It's not going to go away, but it helps a lot.
Yeah, my 1 to 2 patches is the 0.1. So you've used a lower dose patch, so you probably don't have the amount of serum estradiol you need to really suppress the hot flashes totally.
But it is a help, doctor. I will tell you that. Anybody that goes against the E-patch, I will stand up against them because it is a help. Very positive. Granted, it's taking its time to work there, but I'm looking forward to it as it gets better and better. Thank you, doctor.
Thanks, guys.
Rick, you got your hand up.
I do. First of all, Danny, I am so pleased that you've gotten through this, because it's been super rough, I know, on you more than most. And the next time we see you next week, we hope you'll have a full head of hair, but we don't know. Secondly, go on,
Well, I was gonna say I don't care about the hair so much. I want my beard back. I like had such
Oh, you want
pride
your
in my
beard back.
beard. And
Okay. Well, maybe the wife is liking you without a beard. Have you checked in?
She loves me either way, but still, I want the beard
Okay.
back.
Now,
Danny, I got to tell you, don't listen to him about the hair coming back that quick. That's why I wear the cap still. The hair's not there, facial or head-wise. It takes a while. It'll take. I'll be going a year come May again, so it's not there. Believe me. Don't tell him that, Rick. I don't want to give him
okay. Well, we don't know. So I'm just sort of teasing him. Secondly, how are you managing with your medical leave? Are you doing okay?
It's you know, I will say my mental sharpness is horrible. I mean, chemo has been physically the hardest thing I've ever done in my life, and I am so grateful that I was able to get through the 6 sessions. But the one thing that I'm having a problem with is just my mental acuity, my mental sharpness. Yep. Anytime I do anything that's procedural or critical thinking or paperwork or computer work, I just it's a new space for me. I'm not able to process information the way I have in the past. Right. So, you know, I'm kind of nervous about going back to work, and I run out of medical leave on right around the first radiation session. So I'm kind of nervous about that.
Okay. Are you pushing your brain every night? Are you doing puzzles? Are you doing something that forces you to remember? Sitting down and doing like an hour's worth of that?
For sure. Reading in certain tasks. I do a lot of building and putting things together and tinkering with stuff in the garage. And it requires me to, you know, think outside the box and challenge myself. Reading being number one. But, you know, not like my work requires. My work, it requires a certain amount of tenacity.
I get it, because your executive function is also compromised. And that's the problem. But I can tell you what I did was I stopped playing bridge now, but I played online a rubber bridge just so I made myself try to remember the cards.
Yeah. Oh yeah. Spades and hearts and gin rummy. I'm doing all those.
Right. That sort of thing. So you remember what's gone. I want to say one quick thing about the estradiol. First of all, you need to make it very clear to Dr. A that you're talking about using the estradiol as a supplement and not in place of the Orgovyx, because he may be thinking that, and you want to use it to address the symptoms. That's the first thing. The second thing is that the work that's been done on doublet with estradiol is very, very limited. The only thing I could find is an arm of the Stampede trial, which only had about 75 people in it, where they used estradiol. I think it was with enzalutamide or apalutamide. I can't remember. I'd have to go back and look. I do have it bookmarked. So we don't know, and all of the estradiol work that's been done with the patch study has only been done in the context of monotherapy ADT. So Dr. Paul, do you remember the reference for the Stampede trial with the ARSI?
Yes, and it was only with 96 patients, and it was abiraterone and enzalutamide. But think of this, the EMBARK trial, which is enzalutamide monotherapy, drives up estradiol, as evidenced by the fact that gynecomastia occurs. Why does it do that? Because testosterone goes up, because it's blocked at the receptor, and the more testosterone you have, the more estrogen you make. And so in that EMBARK trial, enzalutamide is coexisting with estradiol in a very, I'll say, happy state, because there were no adverse events that were reported. So I hear what you're saying, Rick, but this is a biological agent, and it is much more natural than the LHRH analogs, antagonists and agonists. And yes, you can make an argument, but I think there is a reasonable way of countering the argument from a biological and experimental status, as I mentioned.
Annie, I have a question for you. You said the oxybutynin was not working for you. Are you still taking it?
I took it for 2 weeks, Lynn, and I gave it a shot. And I asked, is that enough time? Did it require a ramp up? And they said, no, it should be effective in a day or so. And it didn't change anything. It changed nothing. And I was under a super low dose of it too. So
you stopped it?
I did. I in consultation with my doctor, I said, hey, it's not working. So I'm just going to back off this.
I mean, I was going to suggest that you do that because that has anticholinergic properties, which can cause cognitive deficit. So I'm not a big fan of oxybutynin. I know some guys here like it. They say it works well, but I think it's a bad idea personally.
Thanks, guys.
Yeah. Okay. Thank you, Danny. So now I know Lee is here, not Lee Balin, but Lee is here with his wife. And Rick tells me you folks are new. You're newbies. Yeah, unmute. Because
all right, I think I put myself off mute now.
No.
Yeah, I can hear you now. All right, so you're new, right?
Okay, yeah. Thanks for.
Okay. Well, I can't. Unfortunately, I'm going to have to ask you to come back next week because if we go to you now, we'll leave about 8 guys stranded to carry over next week. So it's better if you come back next week on Tuesday at 6 p.m. Eastern. Can you do that?
Terrific. Yeah, I apologize for being late. I had a great problem logging into this system. This coach.
Yes, I have too. So I'm sympathetic. All right, we'll see you next week. You can stay if you like, but we'll give you the royal treatment next week.
Terrific. Thank you.
Okay, thank you. Now we'll go to the other Lee, Lee Balin. Go ahead, Lee.
Hi, thanks. I have I guess it's a quick question. I'm giving the consideration to switch from abi+prednisone to darolutamide, and I'm looking for mainly to avoid some side effects, primarily fatigue. And I'm wondering what people's experience have been with that switch. I've been on abi for 6 years now, and I'm also not too happy about being on prednisone that long, which is why I'd like to get off of it. I'm looking to see what positive results people have had from the switch.
Okay, so I switched from abi to darolutamide many years ago. You'll have, well, I shouldn't predict anything, but the great majority of guys have less fatigue, less brain fog on darolutamide because it doesn't penetrate the brain. So, if you're going to be in the overwhelming majority, you'll be happy you made the switch. I'm sure there are a few other guys here who've made the switch. I think Dr. John has done it, and David Muslin, but he's not here tonight. So, anybody else want to chime in on this darolutamide switch from abi?
It went fine for me. And I was having all kinds of other troubles with the abiraterone more than brain fog. So I can't track that one particular symptom for you, but the transition was fine. Just taper off your prednisone over a few weeks.
Yeah, good point. You've been on the prednisone for a long time. You'll have to very slowly wean yourself off.
Yeah, I'm prepared to do that. In fact, I've already talked to my PC doc who will monitor cortisol to see that the adrenal gland kicks back in at some point. So I hear there's nothing negative, it sounds like, from this switch.
Let's find out. We got a couple more here.
I would actually say there's something also very positive. To have been on the abiraterone for that long scares me personally, because when I've seen people on the same ARSI agent for that long, are you also on Lupron or are you on monotherapy?
I just switched from Lupron to Orgovitz a few months ago. I'm still on doublet.
I think there's a couple of things. I think I would be talking to my doc about even doing monotherapy. One of the things that we want to do is keep that cancer off balance. So yes, it's a great idea to switch. And it may even be after 6 years, you may even be able to do it as monotherapy darolutamide, which is what a lot of our guys do.
And drop the primary ADT altogether.
Right.
What are the risks of that?
Well, Len, you've done it. Why don't you answer? Better appear answers.
So Lee, I haven't had any ADT drug in the last 6 years. I've been on intermittent monotherapy with darolutamide.
Because part of my sense is that my test, I've given some thought to vacations, but my sense is that my testosterone isn't coming back, having been this long on suppressant. So,
okay, so nevertheless, dropping the ADT will further get rid of fatigue. So if you're on monotherapy with darolutamide, you should have almost no fatigue. When I was doing that, I felt like I was taking a placebo.
All right. I think my next session with my medical oncologist is going to be a long one. We got a lot to talk about. Unfortunately, he will discuss anything and pretty much try anything, but I'm not sure I want to try anything.
Okay.
Right, this has been helpful.
Yeah, good.
Okay,
Thank you, Lee. We're going to move on to David Yaddle.
Hi, yeah, I have a question. Is this audio better now? I've got on a
Yeah,
headset.
you're good. You're good.
Okay. I'm not positive this is appropriate for this forum, but I had a question about the PCRI conference in LA in September. If others have gone and feel that it's valuable to go.
Oh, I think that's a good question. Anybody like to speak up on that?
I'm sorry, I missed the question. What was it? What was the question about PCRI?
Is it valuable to go to the conference? I'm considering going in it's September 18 through 20 in LA.
Yeah, I think a lot of guys find that it's very helpful. You can interact with the other guys, maybe some guys with your particular disease state. It's kind of entertaining with Mark Moyad. He's a funny guy. Sometimes they have good speakers. I haven't gone in a few years, but when I did go, I always thought it was worthwhile. I don't know, anybody else want to chime in?
I'm looking at we've still got 35 people, and I don't see any PCRI alum on here. That's kind of the problem. Oh, Luther Cowden, you were there when I was there last year. What have you got to say?
I've attended. I've attended three of them, and
okay.
I think they're very beneficial, not only in the presentations, but just in talking with other people who may have similar experiences, and I found they very rewarding.
Okay, thank you. And also, Sylvester had his hand up for a brief moment. I know he goes just about every year. Yeah.
Go ahead, Sylvester.
I recommend that anyone, any male, whether he has cancer or not, attend that session. I
Which
have
session?
attended
He means the conference.
The conference, okay.
Prostate Cancer Research Institute in Los Angeles. It's valuable material for people who have or those who do not have cancer. It's an excellent conference. I went to it many, many times. I missed last year, but I've been going to them for about 20 years, and I don't have a metastatic condition. But the information that I got that helped me was absolutely paramount in my treatment when I did have prostate cancer. I discovered that because, in fact, that's where I met Rick, and he turned me on to AnCan. I can't recommend it enough. And there is one other thing that most people don't know. If the fee is only, I think, $60. But if you are a veteran, it's free.
All right.
And most people don't know that.
So it's actually $30. It's actually $30 this year, and we will be putting a post in all the reminders starting this Wednesday for the active surveillance guys. We will have a table again there this year. Bill Franklin will host that table. I won't be there. We will also probably have a get together for all the AnCan people who are going to be there. Off the top of my head, I remember Tanya Dorf, who is an excellent GU medical oncologist, is going to be there. My own doc, Matt Roach, is going to be there. And a couple of other good people. I don't remember them all off the top of my head. Most people who go find it very useful and very helpful. Not everybody, and some of the information we have to take with a grain of salt, because it is hosted by PCRI and they treat in a very unconventional fashion. So the way that what they may do, it may not be what your doctor would do, but there's a lot of stuff to talk about. I wonder if they're going to get estradiol onto the agenda this year at PCRI, Dr. Paul. They should have asked you to be there. I don't know.
Well, I've talked with Mark Moad, and hopefully he got the message and it'll at least appear.
Okay. All right. Well, so, maybe we'll talk a little bit about E2, but I think it's worthwhile. There are nowhere near as many vendors as there used to be. That was a lot of the fun, the vendors. But yes, we'll be asking for volunteers too, to help us man the table, to help Bill man the table, so that people coming around our table can hear more about the experience of being at AnCan. So.
Okay.
Thank you all.
We move on, Dave.
Yeah, one quick note. I mentioned that I got my PSMA scan last week. I still don't have the results. I see Dr. Cheng tomorrow. I'll have them tomorrow.
Okay. Be sure to send them to Dr. E. Be sure to send them to Dr. Efstathiou.
Roger that.
All right. Next we have Tony Fig. Go ahead, brother.
I had a PSMA test in February and it didn't show anything. I've been pretty much in remission for 2 years, and over the last year the PSA has been going up fractionally, and so I had the PSMA test done in February and it didn't show anything, but the PSA doubled the last quarter. So Dr. Garcia ordered an Axillary scan for me, and I just received the results of that today. And confusing. It said that I didn't have any known metastases, no radio tracer, avid distinct metastatic disease, but it did point out some nodes that were being affected, and also there was something, an image in the rectal wall. So I'm going to be meeting with my GU medical oncologist on Friday to go over it and see what plan of action it might require. Rick sent a couple of suggestions to me by email what to bring up to the doctor for suggestions for treatment. But I don't know if it's not metastatic. I'm unsure why
No,
something show up for the nodes.
it doesn't say it's not metastatic, Tony. It says no distant metastasis.
Okay.
Okay. So we have to separate in our minds what the difference is. Unfortunately, it is metastatic, and although the lymph nodes, I think, which were the axillary node and the, started with an O. What was the other one? Oh, I should.
An
write it down.
axillary node is distant.
Is the axillary node distant? I'll tell you what
Yeah.
I'll tell you what they are, John, because I've got it written down. Let me just pull it out. So I don't know where these. Hold on a minute, Anthony.
Lapdog axillary node.
Figueredo, got it. Okay, so it was in the obturator, the right obturator, and the left axillary, Dr. John. And what I suspect is that both of those are metastatic, but they're not. What it said was, if I remember correctly, there was no distant metastasis in the bone, is what it says. Isn't that right? The report?
It didn't say, it just said no radio tracer, avid, distant metastatic disease.
Distant metastatic
Anything about bone.
Right. So it doesn't see distant, but it sees a couple of lymph nodes that are not really considered to be local. So you have nodal metastasis, which a lot of guys in here have. Now that's way better than having distant metastasis. Way better. The question is, how are we going to treat it? And I'd like to hear what Dr. John's thoughts are, since he knows exactly where the obturator and the axillary lymph nodes are. We may be able to shoot them and use metastasis-directed therapy and nothing else. We may be able to shoot them and add some hormone therapy. And what hormone therapy you add is negotiable. Or we may not be able to do it and you just have to do something with hormone therapy. But those are the options. In addition, there is something in the rectal wall that they're concerned about, which is local, which is a local metastasis.
Urinary tract for the rectal, and I couldn't understand why that was an issue.
Well,
guys, aren't the axillary lymph nodes in the armpit? I mean, that's pretty distant.
I think it's iliac. I think it's misread as iliac.
Can you spell it, Tony? Spell it exactly from the paper.
I can spell it for you. Now, I've seen it, John. It's Axillary.
Yeah, that's on the upper body.
Those should be fairly easy to biopsy.
I've never seen one there.
Oh.
And John, I think I sent you the report. I forwarded it. I forwarded it a reply, and you have that report.
Okay.
On your computer. You know, if the report is coming back saying no distant Mets, you need to go back to Guecho as soon as tomorrow and say, what does it mean, no distant Mets? Because the axillary is distant. Where's the obturator, John?
That one's down low.
That's in the pelvic region.
Okay.
Lower pelvic.
So ask for clarification on the obturator. Somebody, I think it might have been Dr. Pierre, said, well, we could possibly biopsy the axillary because it's reachable. Is that what you were saying, Dr. Pierre?
Yeah, I'd get him biopsied and send some somatic testing on him.
I mean, that's a very good suggestion. I didn't include that, but you know, if in fact it is the axillary, I mean, I think that probably what they meant was there's no distant bone metastasis, but they just say there's no distant metastasis. So that needs cleaning up. And it's not such a bad report, given we know that you were climbing, and there's something there. I mean, also, you know, I think that if it wouldn't have been for us pushing you to get that Axillary scan, I don't know that Dr. Guercio would have even thought about it.
Right.
Right? I mean, he didn't suggest it. We suggested it, and it wasn't easy to get. It wasn't, oh, yeah, well, no PSMA, let's just go get an Axillary. No, we had to push that hard to get that. And unfortunately, that is a situation that is currently occurring. There is actually there's actually a trial going on right now. I'm trying to remember. I don't think it includes men who are recurrent, if I'm not mistaken. But there is an Axillary trial going on.
Rick, we've got some hands up. Dr. Pierre and then Steve Lodge.
I already got mine in. Thank you.
Okay, I was, Tony, you said your PSA was increasing, but what levels was it at?
I had one done today, but I haven't gotten the results. But it went from 0.27 to 0.54 in 1 quarter.
Share. I don't know.
So, you know, it's going from 0.27 to 5.4, and it's most likely going to go up again. And I think the most difficult thing here in the decision making for Tony with Dr. Guercio is, what do we step in with and how much? Do we just do MDT if we can do it, in the interest of doing no harm, which is the way a lot of doctors are moving? Or do we do MDT with a singlet, ARSI, or do we do MDT with a doublet? Any thoughts on that from anybody who's faced this?
The report had tied in it was an ill-defined low-level anterior to the rectal wall image that showed up, but local area of disease recurrent, but the possibility of urinary activity within the urethra couldn't be completely excluded. Does that affect the rectal wall from what that report said?
I mean, the way that I read it, I'm no doc, is that you have an issue in there with the rectal wall. There may be something in the rectal wall. The other thing is that there's something that they can't really tell what it is in the urethra. That could have been urine. So they're not sure. But those are, I mean, I wouldn't, if it were me, those wouldn't concern me so much as the more distant stuff, because you may be able to resolve those if you just went on hormone therapy. And we don't know if you can get, you've had radiation therapy in that area. We don't know how much more radiation therapy you could do. You may be able to do it with cryo or HIFU or something else. We don't know, but these are the things that you've got to be looking into. But it's all very manageable. The SUVs on everything, nothing was higher than about a 6, which from the little I know, you know, is significant, but not super serious. I mean, when we see SUVs, say, of solid known metastases, they can be 11, 12, they can even be as high as 25 or 30 inside the prostate.
What does the SUV mean?
It's the intensity with which that lesion shows up on the scan. How dark it is. That's my understanding. Is that right, Len? And
yeah, well, I wouldn't say how dark,
in the
how
house?
light it is. You know, how much it lights up, meaning that there are more cancer cells. A higher SUV means it's a larger sized lesion that's picking up the PSMA radioactive.
Well, not PSMA in this case.
Oh, in his case, it's Axillary, yeah, which is an amino acid analog.
And estradiol be used for a monotherapy?
Well, I suppose if your doctor is willing to prescribe it, but it seems like many doctors don't want to go near it.
And you know, here's the thing. Here's think about the estradiol in the same way that you think about Lupron or Orgovyx or any of those drugs that you've been on before. Okay? So the question you're asking is, could we just use a monotherapy ADT or transdermal estradiol? And yes, it's definitely a possibility if they would do it, and if you'd rather do that than the ADT. The other side of it is, do you need more than just that? Do you need an ARSI? You've never been on an ARSI. Do you need something like abiraterone or enzalutamide or apalutamide or darolutamide? And if you do, which one? And could you do that on its own? Now, all of this in the context that you don't have, thank God, a huge amount of metastasis.
The process of getting the Axillary scan was kind of interesting. The Blue Earth diagnostic that makes the F-18 sends it to PatNet Solutions in Cleveland, Ohio. They prepare a kit.
Okay, Tony, can we do the very short version of this, because we're really late?
Yep. Well, the end of that story is they drive it from Cleveland to Rochester, and it just seems like it's quite an unusual way of getting it around.
Right. I mean, the logistics are an issue. We've pointed it out to Blue Earth. The first Axillary scan they sent was not of good enough quality. We've pointed that out to them, and Tony had to wait an extra month to get another date. We've pointed that out to them.
All right. Thank you very much for your input.
All right. Thank you, Tony, for sharing. And we'll go to Brian in Seattle.
And Tony, please be sure to bring up Dr. Pierre's point about, is there a value to biopsying it? If for nothing else, it would give us a very good reading for somatic testing.
Okay. All right.
Can you hear?
Brian, go ahead.
Not great. Go ahead,
Not-
Brian.
Can't hear me too good?
Yep.
Fine right now. Yeah.
Okay. Just really quick, like what I got done is I did make an appointment with Dr. Martin Mao at Fred Hutch. I can't see him for 30 days. So I'm on a list to get in sooner. Dr. Martin Ma. I did try to get in Jonathan and Dr. Jonathan Chen all the time. He never returned my call. I actually went to the hospital and talked to him. But I did get a bone density scan scheduled and a testosterone test scheduled, and they actually just sent me a thing right now via community care saying they're going to do the germline and somatic testing because it was scheduled for November. I said I need it like right now, so I just got a thing like a half hour ago saying they're going to do community care for that. So I'm working on everything. So that's right now.
Okay. Have you haven't started the ADT yet? Have you?
No, I talked to everybody about it. No.
Okay, so don't take the ADT until you've done the testosterone test. It doesn't matter about the other tests, but the testosterone test, you got to get that done first. And how are they going to do the somatic test? From your a blood liquid?
I'm not sure on that. I just got the message like 30 minutes ago.
Okay, well, they could also use your biopsy because it's very, very recent.
Yeah.
So that's probably what they're going to do.
See my primary care Friday at the VA. Because I had like 15 things I need. He gave me a few of them. I did mention the medical oncologist, Dr. Schweitzer, and the few others there. He was saying, yeah. He says, I said, look, I really need this thing now. And so he took a picture, but in the notes, he's going to leave that up to the radiation oncologist that I see in a month. And then we did go over the Decipher score. I called Decipher once today, and I said, hey, what does it take to get that Decipher grid report? It just takes a doctor to call. So I tried to tell my doctor this on Friday, and he was just about to make the call. He said, what's the phone number, Brian? So and then the other doctor in the room said, I wrote it all down, doctor. We'll call later. Well, when I read the notes today, he says he just said he's going to refer it to the radiation oncologist that I'm going to see in a month. So I just sent him another message saying, hey, I don't know why this didn't get ordered. I'll call them again today. All you got to do is
okay.
call them.
So if they're going to do a somatic report, I will ask Dr. John for his opinion. But in my view, if they're going to do a somatic report anyway, I wouldn't be so concerned about getting the grid report. What would you say, Dr. John?
No, the grid report, the only thing I think it might have to offer us is the radiation oncologist, if they do that PORTOS, P-O-R-T-O-S scale on the grid report, might give the radiation oncologist a little information about what dose to use. There are other parts of the grid report that will make a suggestion about how sensitive he will be to androgen receptor directed therapy. That won't necessarily come up on genomic testing. It's not critical. It should never be critical because it is actually a building database and not ready for prime time for clinical use yet. So I don't think you have to fight too hard for it if they don't give it to you. But if you can get it easily enough, I'll go over it with you. Rick is right. You know, there's like 22 genes on there and a really big RNA signature. And there's a certain amount of duplication with your genome, with your somatic report.
Okay, thank you.
Hey, Brian, we're desperate to move on. Can we?
Yep.
Okay, thanks. So we're going to go to Gary Martin and then Dan in Schenectady, and that'll wrap it up. Go ahead, Gary.
Yeah, my question was about accessing estradiol, and I think it was addressed earlier, Dr. Paul and others. So I'm
A
just going
little
to
louder, please, Gary.
Yeah, I was going to ask about accessing estradiol.
Right.
I think it's been addressed earlier, so I'm good for now.
So, Gary, are you planning to attend the session on Thursday?
Yes, definitely.
Okay, so through our own advocacy and activity, we have assured that there will be a genitourinary medical oncologist present in that session, because neither of the doctors presenting, nor Dr. Paul, with great respect, are GU medical oncologists, who are the ones most of the time we're asking to prescribe.
Yes.
And on the other hand, if Dr. Paul still had a license, we could make a lot of money for him, because we send everybody to Dr. Paul's practice, and he'd be happy to prescribe the E2. But that isn't sadly the case. Now, the GU medical oncologist is Rohit Bose at UCSF, who's solid. Used to do a lot of work at the VA. He used to be the main GU med onc at the San Francisco VA, and it's going to be interesting to see what he says, and probably he'll get a bunch of questions. There'll be a bunch of questions, because the patch study per se is not so relevant to many of the guys who are on here, who are coming in, who are on doublet therapy. It's relevant. The doctors can't hang their hat on it. That's the problem. We've got to find something for them to hang their hat on, and
Right.
that's where the issue lies. But have your questions, send them in ahead of time. I urge all you guys who want E2, you can send your questions in ahead of time for this webinar. It's only an hour. Go ahead and make sure you send them in.
Okay.
Any other advice, Dr. Paul, on how we get that E2 discussed for all of our gents?
Oh, you covered it. Yes.
So there you go.
Okay. Thank you. And finally, Dan in Schenectady, and looks like you have your wife with you tonight.
I do.
Hello. What's your wife's name?
Linda?
Linda?
Yes.
Okay, welcome, Linda. So who's going to talk tonight, Dan or Linda?
Dan.
Okay, go ahead.
I would give it a shot and hope that I'm clear and to the point. A lot has been happening last week up until today. I got the date for my biopsy, and that's September 2nd. I got the date for my spine MRI, and that's October 10th. And MSK, they finally agreed to reach out to Albany Medical Center Hospital to find out what they need to get that Pluvicto rolling. And the Ogrovix, they got the pharmacy to approve it, and so they're going to call me once I get it in my hand, and give me the directions on what to do with that. And the same thing with the darolutamide, and that's still going through the insurance process.
Okay, a lot of progress there, Dan.
Yeah, all in a week.
Great job.
Okay,
Great job.
Thank you.
So what are you actually on right now? Because we tend to think that your Lupron has expired. The Lupron, the last shot that you got, is no longer working.
No.
Are you still taking the abiraterone?
I'm still taking that until I get the darolutamide in place. You know, so they'll wait for instructions when to stop that and start the darolutamide.
Okay, it's not the stopping the abiraterone we're concerned about.
It's a prednisone.
Right.
Yes.
Good job.
Yes. So once they say to stop the go on the Orgovix, I'm going to present that to them and say, okay, what do I do about the prednisone?
Talk to your doctor about how to
wean off it?
slowly wind it down. He should be able to give you a schedule of how to cut down on the prednisone.
Right. Right.
And the darolutamide is going to replace that abiraterone.
Right.
The Orgovix is going to replace the Lupron.
Yeah. Okay. Yes.
And the darolutamide is going to replace the abiraterone and prednisone.
Right. Right.
And you will not need anything. You won't need prednisone with darolutamide.
Right.
And the darolutamide Nubeqa will replace the abiraterone.
Right. Right.
Now,
right.
Bottom line, we hope that the darolutamide will give you more energy, as you've heard us talk about tonight, and reduce your brain fog.
Yeah.
Okay?
That is my hope. Yes. Yes.
I don't know, given what's going on with that MRI you need on the spine, and where are they going to do the biopsy in the spine lesion?
No, the scapula.
In the scapula.
Yeah.
That's interesting because I didn't think they really like to do them in the scapula because it's a smallish bone. But if they're willing to do it and they're comfortable, that's fine. It's, you know, they won't do them in the ribs. We know that.
Right.
Scapular, I think it all depends where. If it's round the back, they're happy to do it there. But anyway, it's good that we're getting all of this done. And what's your PSA level right now?
It was 2.06, the same as it was last week. That's my last one.
Okay. So I think a discussion that's worth having with Dr. McHugh is, do you really need to do a biopsy of my scapula, or can you not do a liquid biopsy given that my PSA is 2.06? What do you think about that, Len and Dr. John?
I think it's a reasonable approach because there are problems with bone biopsies. Sometimes the cellular content gets macerated while they're trying to dissolve away the bone so they can get at the cells. So yeah, have a discussion with your doctor about the alternative of having the liquid biopsy, which is just a blood draw.
Okay.
Right. See what he says. Yeah.
Right.
And talk to him about, you know, what's the likelihood of success doing a biopsy on bone.
Dr. John?
Yeah, I'm with Len on that. If there's enough circulating tumor DNA or circulating tumor cells in the blood, then it should be adequate. And with your cancer apparently active right now, then there ought to be. And it's so much easier.
It's so much easier. And there is plenty of evidence, documented evidence, that a blood biopsy is better than a bone biopsy.
Okay.
So, and you don't have to go through the procedure of having the bone biopsy.
Right, yeah.
Now, I will tell you that if you're doing this through MSKCC, they're going to analyze that through their own records. They're not going to send it out to somebody like Tempus or Foundation Medicine. You can ask for that as well, which frankly I would, but they may not agree. You can ask for it as well, but they do it all themselves. Len, what's your experience on that issue?
I'm sorry, Rick, I was typing something. What's the issue?
That they will use the in-house analysis at MSKCC rather than sending it out.
Yeah, it'll certainly take a lot longer to get results from their in-house gene analysis program. I don't know if they'd be willing to send it out. They should be, I guess, if you request it. But it will probably ask them how long it will take to get results back from the in-house genetic sequencing.
Okay.
It could take,
I mean, I think I might go at it a little differently and advocate for yourself here with you and Linda together. Tell them that you've heard it takes an awful long time to get the results back when they do it in-house, and you would really prefer that they can do it in-house, but you'd like a sample sent to Tempus.
Tempus.
University?
TEMPUS. We'll put it in the chat window. I'll put it right now in the chat window. Or there are others, but we kind of like Tempus. We think their reports are solid and good. Oh, I sent that just to Len. I meant to send it to everybody. I'll try again. Tempus. Everyone. There you go. Tempus. TEMPUS. So,
Dan, let
what
me
I'd
just,
say, yeah.
Yeah, Rick, I just want to make sure Dan understands. Rick mentioned that you don't need, darolutamide does not require prednisone, which is true, but you will still need to take the prednisone because you need to taper it down even while you're taking the darolutamide, right?
Okay.
You got, okay. Yeah. Just want to make sure you understood that. Yeah. Go ahead, Rick.
No, that's it. Yeah, and make sure you taper slowly. The doctors sometimes say, oh, you can come off in 2 weeks and 2.5 weeks. That sends shivers up our spine.
Upper 10.
What's the normal time it would take me to taper off the prednisone?
Oh, they have to cut down the milligrams. It's up to the doctor.
Right. Exactly, yeah. Linda.
Because I'm on it as well. I'm doing a tapered. So.
Right. And you just go, and there is no normal because a lot of it depends on how long you've been on the prednisone.
A lot of it will depend on what symptoms you may experience while you're tapering. If you're tapering too fast, you may have some swelling tissues. I mean, you should talk to your doctor. What could I expect if I'm tapering too fast on the prednisone?
Right. One thing that we've seen when you taper too fast is you just lose your appetite completely.
So even on a 5 milligram, dose of prednisone, so it would take maybe a half and then go to a quarter.
You could do something like 2.5 milligrams a day for a week, and then 2.5 milligrams every other day for a week and off if you feel well. That's the way I did mine. Some people even have to go slower. But you haven't been on it all that long, have you? How long's it been?
I think about, if I'm right, I'd say since February.
Yeah. So my schedule will be the fastest you'll do it. 2.5 for a week, 2.5 every other week, and off. And if your doctor advises you to, take it longer, even longer than that.
Okay.
Jim?
Jim, yeah, you had your hand up.
Muted, Jim.
Yes, I was on it 5 years, and I went 2.5 for 2 weeks, 2.5 for two more weeks every other day, and then a week every third day, and I was off of it. But I was on it 5 years. So.
Don't worry, you won't be having to cut up pills. We'll figure out a way so you don't have to cut up those little pills. Otherwise, it's a right mess.
They do have the 2.5s in pills, if I remember correctly.
Yeah. I think I have like bottles of prednisone.
Yeah. All right. We're
Can I ask
down.
a quick
Yeah, go
one
ahead,
question
Linda.
on the Tempest, the oncology one that we're gonna ask them to send the analysis to? Is that an additional insurance approval or just, you know what I mean?
Yeah.
Like MSK can just send it there if they would, without an issue, or like who pays for that, in other words?
So here's the issue there, Linda. There's no question that insurance will approve a somatic test because it's in the standard of care. The problem you're going to be faced with is if MSKCC says we want to send it internally and you want to send it externally. And then you've got to say to them, look, you can send it internally as well, but that's on your dime. As far as our insurance is concerned, we would like it sent to Tempus because we want the results back quickly.
Okay, so we're only going to have Tempest do it instead of MS to the both, if that's the way it could happen.
That's what I would try and advocate for. Okay. At the same time, they may say, "Oh no, we've got to send it." Well, if you insist on sending it, then that's on your dime. We don't want to be waiting around for months to get a result, which is what happens. You'll get it back from Tempus in 2 weeks. And if they give you grief, you say, okay, if you got it, we'll do it with MSKCC, but we want a commitment from you that on your expense, you'll send it to Tempus if it's not back in 2 weeks. And they know it won't be back because it never gets back. It takes forever, doesn't it, Len? I remember.
Well, it took 5 weeks for me, but that was quite a few years ago. So I don't know if they're improved their turnaround time.
That's all I wanted to ask.
All right, Dan, are you good?
I'm good.
All right. Good luck. We'll see you next week. And thank you, everybody, for hanging in there all this time.
Nice job, Len. Nice job.
Good job, Len.
Thank you for your contributions.
Thank you.
Thank you.
And we'll
Very
see you
good
next
job.
week.
Thanks,
folks.
Len. Thanks, guys.
Hey.
Night.
Thank you.
Night.
Night, everybody.
Night.
Thank you, Len. Thank you, Rick. Good night.
Good night. Good night.